So we use stories in all sorts of different ways. But how does it impact cancer? Well, I'm not sure what you watch, but this is perhaps a slight thing of some of the stories I've watched. Yes, don't worry, some of this picture is a little bit merged out. So when we look at stories of fictional characters, and we've got stories of reality TV stars and famous personalities and how cancer has impacted them. So we've got Jean Slater, who, if anyone watches EastEnders, had ovarian cancer. And when her storyline came out in EastEnders, lots of people started to Google the symptoms of ovarian cancer, and they started to Google how to get help and what could they do. We've got Rebecca Pearson, who, if anyone watched This Is Us, she thought she might have breast cancer. And the storyline was about the BRCA gene. And this kind of triggered lots of people to search for stories about genetic testing in breast cancer. And you could see the impact of this storyline straight away. For anyone that's watched Love Island, that's Chris Hughes at the bottom having a rather intimate exam live on TV because his brother got testicular cancer. So he decided to use some of his fame to try and warn people and tell people about the symptoms of testicular cancer. And part of that was having an exam live on TV. And that was to take away some of the stigma of those tests and also to take away some of that worry, because if you think you might need to go and be tested or have something looked at, you might not know what's going to happen in a GP appointment. So he did it live on TV to find out. And then finally, at the bottom, if anyone's into cycling, you've got Sir Chris Hoy, who's just been told he's got metastatic prostate cancer. And after his diagnosis, what happened is charities started to see a massive increase in people Googling the symptoms of prostate cancer. And lots of people started to turn up to the doctor and ask for what's called the PSA test, which is a blood test to see if you might have cancer. And this, you can see through these famous people that they're triggering a behavior in people, but it's just them sharing their stories and experiences. Now, the most famous thing and the most studied effect we've heard is called the Jade Goody effect. Now, I don't know if any of you have heard of Jade Goody, but she was a contestant on Big Brother many moons ago. And sadly, she got diagnosed with cancer. And what you can see here is this, the line at the bottom, the lower line, shows how many people you'd expect to go for cervical screening, how many women. And then you can see just after her diagnosis, there was a massive increase in people that went for cervical screening. It then dropped off again. But then can you see when she died, how many extra people came up for cervical screening? She had a massive impact on getting people to the doctors. She shared her story and her experience of her symptoms and everything that was happening to her, and it had an effect on people. Unfortunately, as you can see, the effect didn't last, it dropped off, but there was a massive effect on behaviour just by her sharing her experience and her stories of these symptoms. So how does that relate to health research? How does that relate to what we do? Well, as we said earlier, my name's Jennifer, and I'm a researcher, and what I look at is inequalities in cancer pathways. I want to know when something goes wrong, why does it go wrong, and who does it go wrong for? You can only get so much of that information from numbers and questionnaires. What you really need to dig deep into why these things are going wrong is what we call qualitative research. And qualitative research is words. So I avoid numbers massively. I hate numbers. Numbers hate me. We both make each other cry. We stay far, far away from each other. If someone gives me a statistical test, you'll normally find me rocking in a corner. I don't do that. I can't do that. I really, really can't. But what I can do is I can talk to people and I interview people. I drive around the country, I go to their houses, I talk to them about their experiences of cancer or their experiences of going for screening. And I talk to them in groups. We have focus groups where we get groups together to talk about a topic. And we look for themes and patterns within these conversations to try and see what's coming through. What are the topics that are coming through? What are the themes that are coming out that really are causing people difficulties anywhere along this route to a diagnosis of cancer? because there's lots of things there, and the only way we can really get to them is by digging deep. So how does this kind of create research questions? Where do research questions come from? How do we know what questions we want to ask when we're looking at cancer? Well, we talk to people. We talk to people constantly. I never stop talking to people. But one of the main places we use is through charities. And this is just a list of some of the charities we've been working with recently. And we go to charities because they hear from people who have certain health conditions, certain types of cancer, and they build up a view of what's happening. People go to charities and they say, oh, I'm having trouble with this, or this is really giving me lots of problems. And then they start to go, okay, we think these are areas that need to be looked at. So you can see how these stories and people's experiences sort of trigger the research. And with a lot of these charities, they actually fund the research. So the stories that they're being told on a daily basis cause them to go, right, we'll put some money into this topic. We want some people to dig a bit deeper into this so we can really understand what's going on for people. Some of the things that are coming up at the moment is for cervical screening, you've now got kits that you can take at home and do it yourself. So you don't have to go to the doctors for a smear test. But we want to know, do people really want to do that? Are people happy doing that? Do people feel comfortable doing that? And do they trust the results? So there's all sorts of topics that come through from conversations with charities that then trigger a research question or something for us to look at more. So I'm interested in head and neck cancers. So a lot of the charities and things that focus on this area are the people that I talk to. But how did I kind of get started in that? Where do the patient stories come into that? Well, when I started my PhD, I was told, here's some money, go and look at something to do with head and neck cancer. So I did what I thought you should do. I sat and I read books and I read journal articles. And I thought, right, I know that fear of cancer coming back is the most important topic I should look at. This is what all the journal articles are telling me. This is what everything I'm reading is telling me. So that's what I'm going to do. So I turned up at a patient support meeting and I was like very confident, I'm going to look at this and I'm going to really help you stop worrying about fear of cancer recurrence. And a patient put their hand up and said, yeah, no, I don't like that. And all of a sudden I realized, well, actually, I've decided I don't have head and neck cancer. And I've just gone, I know what's important. I'm going to walk in this room and I'm going to say to everyone, right, this is what we're going to talk about. And then they turned around and went, no, we're not really that worried about that, if we're honest. And then they started to talk about their pathways and their routes to getting diagnosed. And we had this really good conversation and they were telling me about how difficult it was and how many times they'd tried to get diagnosed and the delays in that diagnosis. And we realized actually there's a whole topic area there that they're telling me is important to them. So I'd stopped what I thought I should be doing and I re-looked at it and we decided we'd look at the routes to diagnosis. So the patient's stories and their experiences in this room were what essentially decided my research question, and they decided what I was going to study. And then it's important because then you know you're doing something that people want. You can't just do research because you're just interested in it. It has to be what's important to be done. It has to be what people are interested in and want to know about, and what will help people who are going through these things. As someone who didn't have head and neck cancer, I couldn't tell them what was important about their experience. I needed to listen to them and for them to tell me what was important. So I thought it might be useful to tell you a little bit about how the research was conducted and what results we found, because then you can see how the patient stories and their experiences go the whole way through the research and how important it was to have their words. And really, none of this work could have been done just with numbers. We wouldn't have got to the meat of the issue. We wouldn't have really got to what we needed to be able to look at what we could improve. So we know some people have this beautiful journey. They get a symptom, they go to the doctor, they're referred on, they get diagnosed, they get treatment. And whilst it's horrible they had cancer, there was no delays, and often they got treatment that was curative. But then we also know there's people that have a real tricky path. and they face lots of barriers and lots of obstacles along the way. And when they're getting those obstacles, the cancer can grow. And then in the end, some of them will have a cancer that couldn't be treated. But it could have been treated if they got there earlier. So that's why we realized it was important. We also then started to look at, well, what do we know about this subject? So once you've got the subject idea from the patients that you're thinking to, once you've understood what you want to look at, you can then start seeing what else we know. And what we do know is that if you have cancer in England and the UK, you don't do as well as if you had cancer in Europe. People are surviving cancers in Europe far more than they survive if you live in the UK. We also know that if you've got a head and neck cancer, you're more likely to get diagnosed really late. So they give cancer stages, 1, 2, 3, and 4. If you get a cancer diagnosed at stage 3 or 4, that means it's quite well progressed. It means you're going to have far harsher treatments and you're less likely to survive your cancer. But everyone that was coming through tended to have these higher stage cancers. So this kind of data then added to the picture of the stories we had. And what we were trying to do was figure out what are these barriers and how can we stop them. So this is Rob. I will say these aren't real pictures of patients. These are fake pictures that the patients decided to pick as to who they wanted to look like, because then it's all kept private and nobody really knows who they are. And Rob's a fake name. But Rob was 45 when he got diagnosed with a head and neck cancer, and he lived with his daughters at home and his wife. One of his daughters was a dental nurse, which came in very handy for him because he had a weird lump in his mouth and didn't know what to do with it. And he kept delaying and delaying. And then eventually he told his daughter about this lump in his mouth. And she was like, you need to go to the dentist now and get them to have a look at it, because I think this could be something serious. So he did. And he went along and he made an appointment, but he didn't make an appointment too quick because he wanted to go on holiday. And let's face it, 2 weeks in the sun is preferable to a trip to the dentist, isn't it? So he went on his holiday first because it didn't seem that important. And then eventually he got referred to the hospital for more tests. And then he got a bit more of a delay and he waited for another appointment and then another appointment. And then he was diagnosed with cancer. Now, because he had lots of delays, was going on holiday and lots of appointments, it meant it took him 38 weeks from the point he decided that this was a symptom he needed to do something about to go in and get him diagnosed with cancer. So in that time, that meant his cancer grew to a cancer that was a stage 4 cancer, which meant he had to have part of his jaw removed for the treatment. He felt he'd done everything right and felt he kind of had done what he needed to do. The symptoms didn't feel that serious, so he felt he'd done everything right. But then you move over to Anne. She is 78, and she knew straight away that something wasn't right because her husband had just been diagnosed with a head and neck cancer as well. But she had a really tricky journey to getting diagnosed. She first noticed some symptoms, then they started to get worse. She went to the GP. The GP said she had earwax in her ear and that's what was causing the symptoms. She went back again. She went back again. She went to get her ears cleaned. Then she went back again because the nurse couldn't do it the first time. Then she went to an emergency GP. And then she went back to a GP again. And then she went with her husband to his appointment in secondary care when he was going through his treatment. And she said to the doctor, I've got something weird in my mouth, but nobody seems to be bothered about it. But I really am. Will you have a look? So her husband's doctor looked at it and went, yeah, you need to see me. So she went back to the GP again to get a referral and then was admitted to hospital. And 2 days later was diagnosed with cancer. Now hers only took 23 weeks rather than the same time as his, but because she was in and out to various different doctor appointments and she wasn't really believed and she had lots of pain, she lost a lot of trust in the healthcare system. So when it came to having treatments, she was really anxious because she wasn't sure if she was being told the right things by the doctors. Should I really have this treatment? I don't know. They messed up so much earlier. Can I really do this? Is this the right course? So she got lots of second opinions, which caused even more delays. So even though the two journeys, hers was shorter, because there were lots of interactions with people who didn't believe her that when she was worried, it really impacted the whole experience for her. And afterwards, she's been having lots of problems with really coming to terms with what she went through and doesn't want to ever go back to the GP again. So if she has problems in the future, she won't go to the GP because she doesn't trust them anymore. These are things that don't come through when you think about numbers and when you just get numbers and you just get data. So you might have gone, oh, look, his journey was 38 weeks, her journey was 23 weeks. So he obviously had the worst experience and she had a really relatively quick experience. But the stories and listening to their stories show how the impact of what was happening on this journey changed the whole thing for them. So once I interview people, I end up with pages and pages and hours of interviews that I get transcribed, and then you go through them and you look for patterns. You spend ages, so I'm the sort of person that likes big sheets of paper, sticky notes, things like that. I don't like doing things on a computer. I much prefer sitting down with huge sheets of paper, and you start to put everything together to make themes. And then you can start seeing patterns in the data. And that's when you can start seeing what's happening. People aren't having the same experiences, but they're having similar themes within their experiences. And that's what you can pull out. And then you have your themes. So you pull out your themes from the data. And I thought I'd just pull out, these aren't all of them, but these are just some of the bits that we found were really interesting when it comes to how people face these barriers to getting diagnosed. And we found that one of the big themes that comes through is knowledge, and that people don't really know what cancer is. If someone was to say to you, what's cancer? Would you be able to come up with an answer? Because for many people you can't, because we don't really have a nice understanding of what the actual cancer is. What we know is that it's something that feels bad, it's something that feels like we don't want to have, and it's something that worries most of us. So people's knowledge about cancer is really poor, but people's knowledge about the healthcare system is also really poor. We're absolutely terrible at knowing who to go to for help. And that's not to say that's our fault. That's to say that the NHS is a giant mess of different people and places. And all of a sudden you have to understand how to navigate this huge, monstrous system. You've got to know who to go to, what words to say to get referrals. And you've got to know who you can ring to chase up a referral. And it's a real big, monstrous system that can be really hard to navigate for people. Then some people are on their own when they go through this process. So when you're kind of having to navigate this system and negotiate your way through it, it's important who you have by your side. Some people are on their own and they don't have people to support them. So these are other things that come up. How important is the people around you when you get diagnosed with cancer? What impact do they have? Sometimes they can have a terrible impact. Sometimes they can go, nah, this doesn't look important. You're fine. I had one woman who asked her friend what she thought the lump in her throat was. And she said, I think that's a tonsil stone. I watched a YouTube video about this the other day, and I can cut this out. So she attempted to cut out this lady's tonsil stone. It wasn't a tonsil stone, it was a throat cancer. So she did a little bit of surgery at home and tried to cut it out. So I will say, don't do your own surgery based on YouTube videos. It's probably not the wisest move and can maybe delay your diagnosis a little bit. But people will do lots of things based on what they see and read. And this is what we're interested in understanding. And what we also know is we don't really know what symptoms relate to head and neck cancer. And for most people, if it's not painful, you don't go and seek help. The thing about head and neck cancer symptoms is they're very rarely painful. They're only painful if the cancer's growing near a nerve. But otherwise, it might be a mouth ulcer that hasn't healed for 3 weeks. It might be a sore throat that you still have for 3 weeks. It might just be your voice changing a little bit. And very occasionally, it might be a red or white patch in your mouth. So these are not things that really kind of strike you as being that dangerous or that deadly, are they? You kind of think, well, I had a sore throat a few weeks ago. And then you start thinking, well, have I still got the sore throat? Do I now need to go and get help? But if there's no pain, people often don't go and get help. But what's also important is we don't just hear the stories and the experiences of patients. We need to hear the stories and experiences of healthcare professionals too. Because what's it like when you're the person that people go to for a symptom? How do you know what to do? There's hundreds of different cancers. If someone turns up in your clinic, how do you know that you're doing the right thing? A GP in their whole lifespan of working may only see 6 patients with a head and neck cancer. So how are they supposed to keep those symptoms at the front of their head all the time? So we interviewed them as well. And we found that actually your relationship you have with your GP is really important. If you know your GP really well and they know you really well, they're more likely to pick up on symptoms and things that they need to, and they're more likely to get you referred far quicker. And also we know that GPs who break the rules a little bit tend to help. We have really strict guidelines about when you would refer someone for a suspected cancer. And you've got a tick box sheet and you have to qualify to meet all of these criteria, and then you'll get your referral for a cancer referrer to go into secondary care. But what we do know is that some GPs will tick a box that's not quite true because they have what they call a gut feeling. They look at a patient and they go, they've not had this symptom for 3 weeks, but I'm really suspicious. I know them and something's not right. So sometimes those GPs that break the rules or bend the rules a little bit are the ones that get you seen a bit quicker because they go with their gut instinct and what's important there. Now, the other people I spoke to is dentists. Now, no offense to dentists, but it's terrifying going into a dental surgery to interview them because most of them made me sit in the dental chair. That does not bring back good memories. I'm old enough that when you used to have a tooth out, they used to gas you to sleep. So this was really quite triggering for me going into a dentist room. But they're really, really good at picking up cancers in the mouth. They're amazing. If you go to a dentist, they're the people that pick up those really tiny mouth cancers. And if they pick up your cancer, you're going to get a really quick referral. And often the treatment you need is tiny. For some people, it's just it being cut out. For some people, it's just a bit of radiotherapy, but the smaller amount because they're picking up the cancers that are stage 1. But does anyone like to go and see the dentist here? Or do most people feel a little bit sick at the thought of walking into the dentist room? Well, that's pretty common. Most people hate going to see the dentist. I feel sorry for them. There are some people who people just hate, and they're normally very nice people, but the thought of going to a dentist is horrific sometimes. So we wanted to see what it was like for dentists. What's it like for you when you've got patients who you think might have cancer? And a lot of dentists really worry about how people have to pay them money. So we pay up front at the dentist. And they found that as soon as someone handed over money, that meant they didn't trust them anymore. You may have heard this before. You may have heard people go, well, I was going to go to the dentist, but I see pound signs flash up in their eyes whenever I think of going, and they're just going to do something because it's a bit of extra money. And people don't trust the dentist because they're having to pay. And in this country, we are not used to paying for our healthcare. We don't pay we don't pay up front to go and see a GP. We do pay, but it comes out separately. So we're not seeing that payment. So it's a really tricky thing for dentists to get over, is to really build that trust that what they're asking a patient to do is because it's important, not because they want more money. And also, dentists worry far more than GPs about being seen as being stupid. They don't want to refer someone to the hospital for a suspected cancer if they're not 100% sure they have actually got cancer. Whereas GPs are taught, you send lots of people Most will come back as not having cancer, and that means you're doing a good job. But dentists worry a bit more about that. They think if they send someone and they've not got cancer, then the people in the secondary care might think they're a bit stupid. And they worry about their kind of view of how professional they are. And who knew that a dentist checks for cancer? Does anyone know that your dentist is doing a cancer check every time you go to them? Did anyone know that? Here's a test. Next time you go to your GP should feel your neck. If your GP doesn't have a good feel of your neck, then ask them why they're not doing it. And say, if you don't mind, I'd like you to do the neck check, please. Because what they're doing is they're feeling for lumps, and they're checking to see if you've got any abnormal lumps in your neck. But the most important thing is they need to know your neck, because our necks are lumpy places. So they learn about the different parts of your neck and they feel them, and then they record it so they know when things go wrong and when there's something unusual there. But very few people know that dentists do actually check for cancer. So that's partly why going for your 6-monthly checkup is really important, because they're doing a constant check on cancer. Now, I should say, I don't want to worry you lot. You lot are far too young for mouth cancer. You've got to wait till you're in at least your 40s, but you can share this with parents and grandparents and make sure that they keep going for the checks. And also what you will notice is that dentists actually work quite separately from GPs. And this is really tricky for them, because it means they can't chat to a GP and talk to them about things that might be happening and how they can really understand the care of a patient. For some reason, we've taken the mouth out and separated it from the rest of the body here, and in fact, most places. But a lot of what dentists see link to what a GP would know and understand. They need to know what medication you're on and how that changes things. A dentist can spot if you're a diabetic. Dentists can spot lots of things. They can spot if you might have heart problems based on the state of your mouth. So there's lots of things that dentists can do. So we've got all these stories and we've gathered all these stories and we've got all of these themes, but then what do you do next with it? Well, the first thing we did was we actually changed the referral form that dentists send, because one of the things dentists didn't like is you had to put a GP name, not a dentist name. And it's something really small, but that really helped dentists feel like they were actually referring patients and getting information back and hearing from it. So it's a tiny change that was so easy, but had a reasonably big impact on dentists. But then we also needed to share the findings. So this is where stories come in again. So we used some of the patients we work with would help me share findings. They wrote leaflets with the findings with me. And we're currently creating a theatre show, a piece of forum theatre, because one of the findings that came out was this, how difficult it is sometimes to talk to a doctor or a dentist about symptoms, and how complicated that can be, and how sometimes you just need a bit of help with that. So we're currently doing a theatre show in Leicester, of all places, about this, and where people get to practice doing role play and practice talking to GPs and dentists to see how that helps and see if that will help build that ability to communicate really well. And we've then also got some patients who came and did some analysis with me. So they worked through the transcripts and we looked at something called health literacy. And that's how able you are to be literate when it comes to health behaviours and understanding how to negotiate the healthcare system. And they would come and they helped me go through the transcripts. So they were reading other people's stories as well and figuring out how those stories related to health literacy and how it related to their experience as well. So the stories were constantly coming through. Stories are really powerful when you're sharing research findings as well. When you want people to sit up and change, and a lot of the time when you're working in the healthcare system, you're wanting the government to change policy. You're wanting managers to change things. You can go to them with numbers, and numbers can be reasonably effective, especially if it's related to money and how much money you can save. But stories and people's experiences are emotive, and they really get people invested in making changes when they can hear these stories of what's gone right, what's gone wrong, where the difficulties have been. And sharing those stories with people can often be what helps change policy and practice, because you need the stories with it. A number will only tell you so much. So another study that we was working in rural Yorkshire. So people who live in rural areas have far worse outcomes for colorectal cancer, but we don't know why. So again, we worked with patients who lived in rural areas. We worked with farmers. We worked with people who ran bed and breakfasts in rural areas, and we got them together to chat and talk about these experiences of going to the GP. What's the difficulty living in a rural area to get diagnosed with cancers? And again, this was all about stories. This came about by stories from farmers who were saying about how difficult it was and how often they got late diagnosis for cancer. So we started to interview them and hear their stories. This happened during COVID as well, some of this work. So we inadvertently managed to get to understand what the experience was like of living in a rural area during COVID as well. So we had all of these stories that we could then use to build on. And the results from that were we ended up with an animation which could be shared. And this was an animation about what it's like living in a rural area and having symptoms of colorectal cancer and how difficult it is and how important the GP practice is. So one of the biggest findings we found is most people go, well, if you live in rural areas, I assume you do far worse because you've got to drive for miles to go to the GP. But that wasn't actually a problem at all for people. People are fine driving, they don't mind. The biggest problem is who they were going to see. They wanted to see a GP who knew them really well, and they wanted a really good relationship. So if you lived in a small area with a single GP practice and the GP had been there for a really long time, then actually the people that saw them weren't getting delayed. They were going through the healthcare system really quickly. And that's because they had a GP who knew them. They had a GP who knew if a farmer turned up and made an appointment, that was normally really serious, because farmers don't tend to go to hospital unless a leg's fallen off. Unless something is stopping them milk their cows or do the lambing season, they're not going to go and get help. So if a farmer turns up at the GP practice, most GPs will leap into action and do whatever they need to do because they know it's serious. They know something really bad has happened. But they needed a GP who understood what rural life was like. And it's really difficult to recruit GPs to live in rural areas. So these are the things that, again, like I was saying, you don't often get it when you just look at numbers. But through this, we understood how important this is to have a GP that really understands rural life. Have a GP that won't ask someone to come along for an appointment in the middle of lambing season, that understands that they can't ask someone to drive to a certain hospital in the middle of late January because the roads will be snowed over and they can't get to there. So they need to travel to a different GP practice. So we got through these stories and experiences to understand how important it was that a GP is really embedded within the community. And then sharing stories and experiences can go further. So a study using AI to look at bowel cancer. So they use AI systems to detect cancer on the scans after a colonoscopy. So that's when you've had a camera go through and AI looks at the images and goes, right, this potentially is a cancer. And it's far more effective than human eye at doing it. But what we wanted to understand was the patient experience around this as well. So on here, you've got a patient sharing her experience on Lorraine with Colin Rees, who is the surgeon in charge of the study. And they went and talked about her experience. And she talked about what it was like having the colonoscopy and what it was like knowing the AI was looking at your images. Did they trust it? Did they understand it? We all know how terrible ChatGPT can be on some subjects. So it's, you know, you have to really kind of think, do you trust AI to find your cancer? Do you really think it's going to do a good job? And at the moment, it seems like it is. So we were using that as the next stage. It's like sharing the stories of these findings and sharing them in places where lots of people can see it and understand it. And then people might go, okay, that sounds all right, or I might investigate a little bit more and feel a bit more comfortable about this. So how do stories and experiences drive research? Well, they give us our research ideas, which is great. By talking to people and understanding their experiences, we can find other areas to research. They give us funding, because often people's stories are what get people to give money to a cause, which then gives us money to do the research, which, as much as you put it, we need money to do research. So the funding is really important. But they also, the stories and experiences can be the actual research. That can be the data we're working with, their stories and experiences. It can also be the way we share the results by using stories and experiences to share the results to people, to make sure that our results aren't just written up in a really academic journal that nobody's going to read. So they can be about the dissemination of the research, and they can then trigger more research from there. So thank you very much. It's been lovely to talk to you.